Thank you very much. I'd like to thank the organizers very much and congratulate them on a wonderful meeting, and thank you all. Thank you all very much for your hospitality. I'd like to talk to you about lung isolation as we do for thoracic surgery and minimally invasive cardiac surgery. The diagram is a double lumen tube, and if we put the bronchoscope through the bronchial lumen and look out, we see the whole world, and India's right in the middle. We'll talk about some new equipment, and we'll talk about how we manage difficult airways for lung isolation. Now, we only have three methods of lung isolation. We can use single lumen tubes as a bronchial tube, we can use double lumen tubes, or we can use bronchial blockers. Same three methods we've had for 60 years. And the ABCs of lung isolation is we have to know our anatomy, use a bronchoscope, and check our chest imaging. Now, first method of lung isolation 60 years ago, they would take a single lumen tube, make it long, and with a rigid bronchoscope put it in one side or the other. We can still do this. We have specially built endobronchial tubes. We use them for carinal resections. They have a very short cuff and no Murphy eye. But we don't use them very often. I prefer to use double lumen tubes. That's my method of choice of lung isolation if I can. Now, this is the Carlin's tube. I'm sure many of you have had your hands on a Carlin's tube. Carlin's was not an anesthesiologist or a surgeon. He was a chest physician. He put two small single lumen tubes together, glued them together, and he'd put them awake with topical anesthesia in patients he was doing split lung function studies. Wasn't a really good tube for anesthesia, but it was better than anything else they had at the time. Carlin's tubes were modified in the 60s by Robert Shaw in Manchester, England. He didn't like Carlin's tubes because they're so small. You can't suction through them. They were doing a lot of infectious surgery at the time. So he then came up with a tube that has two D-shaped lumens, very low flow resistance tubes. And he designed special left and right-sided tubes. Left-sided tubes for right-sided surgery, right-sided tubes for left-sided surgery. All of our modern double lumen tubes are based on Robert Shaw's designs from the 60s and 70s. And then bronchial blockers. There's been a real resurgence of interest in bronchial blockers in the last couple of years. This is the Univent tube. Some of you may have used a Univent tube. I don't like it. It's a very stiff tube. I like to use bronchial blockers in patients with difficult airways. I don't find it's a user-friendly tube. This is the ARNT blocker. I think this is available in India. I'm basically sure it is. It's a popular blocker in North America. It was a first blocker that was designed to be put through a standard single lumen tube. ARNT came up with this really nice three-way connector, airtight connection for your blocker and your bronchoscope and your circuits, your ventilating, and you can move your blocker independently. The thing that I don't like about the ARNT design is this wire loop, okay? He designed this to slide down the bronchoscope like a fireman slides down a pole. Now, I don't know if that makes any sense in India. That concept, they do that in North America anyway, and firemen sliding down poles like you see in the picture. That can be an issue. Now, since the ARNT blocker isn't perfect, there are other imitators. This is a Cohen blocker. It's got a wheel. You turn the wheel and the distal tip turns, sort of like a bronchoscope. And this is a Fuji blocker. The Fuji blocker is a very simple blocker. It's just got a hockey stick shape on the end. You turn it one way, you turn it the other. You don't have this blocker in India, but you do have the Coupe deck. Coupe deck is almost identical to the Fuji blocker. Now, there are differences between these blockers. The one is that the ARNT blocker, the ARNT is always behind your bronchoscope. You don't see it until the very end when you slide it off. Sometimes it can get caught at the carina, and you can't see where it is. It just gets stuck. It can be very frustrating. The other blockers, you're putting them ahead of your bronchoscope, like you see in the picture here. If there's very abnormal anatomy, it's a little easier to direct them. And the other thing about these other blockers is you can use them outside of your endotracheal tube if you want to. This is a patient with a tracheostomy. As you see, we've put the blocker through the stoma and then followed with a standard single lumen tube. When you inflate the cuff of your tube, holds the blocker in place. This is very useful in pediatrics, where you have a very small tube that you have to put in beside the blocker. Now, one complaint that people have had about blockers is that if you use a blocker compared to a double lumen tube, the lung doesn't collapse as well. So we decided to study this, okay? So what we're studying here is how well the lung collapses. What we've got is a lung collapse score here on the vertical axis, 10 being complete collapse and 0 being no collapse. And the surgeons are blinded. They're out of the room when we intubate the patient, and we put a drape over the patient's head when we reposition the patient. The surgeons don't know if we're using a blocker or a double lumen tube. And we're comparing, the yellow is the ARNT blocker, the green is the Cohen, the blue is the Fuji, and the red is double lumen tubes. So when the surgeons open the chest, the lungs are all about 60% deflated. No difference. 10 minutes later, 70% deflated. 10 minutes again, 20 minutes, everybody's about 80% deflated. The surgeons couldn't guess if we're using a blocker or a double lumen tube. So blockers, the lung collapses just as well. That's not an issue. What is an issue with blockers is that they're unstable. They can move during the middle of the case. The lung reinflates, you have to interrupt surgery and deflate the lung again. And this is what we found in the same study. There were 26 patients in each group, and this is the number of times after the beginning of surgery that we had to reposition the blocker. 16 times, 2/3 with the ARNT blocker, about 1/3 with the Cohen and the Fuji. Very rare with double lumen tubes. I'm not saying double lumen tubes never move in the middle of the case, but they move less than blockers. So if you've got blood or pus or an air leak, you really would rather have a double lumen tube. We studied the original elliptical. The company discontinued this design and now makes a circular blocker. We didn't study it, so maybe it's better than the others. Now, the newest competitor in the bronchial blocker market is the Easy Blocker, and this is now available in India, okay? When I saw this 4 years ago, I thought, what a stupid idea. This is a double blocker. You see, it sits on the carina, and you've got two limbs, and you just inflate whichever one you want. Well, I am like one of those religious people on the road, you know. I've had a conversion. I've seen the light. This is now my favorite blocker for the last 2 years. One thing is, I think it's more stable. I think it moves less during the middle of the case. And the other thing is, for right-sided surgery, it can't go too far down the right main stem bronchus. So it tends to let the right upper lobe deflate. Having said that to you, we've had this blocker for 2 years at my hospital, and not all my colleagues would agree with me. Some of them are no more impressed with this blocker than they are with other blockers, and we can talk about that later if you want, the complaints that they continue to have with this blocker. Now, if you're using a blocker, there are some tricks to get the lung to collapse. You don't really need tricks with double lumen tubes, but you do with blockers. Okay, first of all, denitrogenate the lung. Once you inflate the cuff on a blocker, any gas trap distally has to be absorbed. If there's nitrogen in there, if you've been ventilating with air or an air-oxygen mixture, the lung collapses slowly. A prolonged expiration, I actually disconnect the circuit, I watch with my bronchoscope, and I wait until the end-tidal CO2 goes absolutely down to 0. I'm ventilating with 100% oxygen so the patients don't desaturate, and then I inflate the blocker under direct vision. Suction, all the new blockers have a suction channel. I put on -20 until the lung is completely collapsed. Pressure control ventilation. If the patient coughs, you don't get a high peak in airway pressure, which will force air around the blocker, if you use volume control ventilation. And finally, warn the surgeon. If the surgeon manipulates the lung a little less, a little more gently, there's less likely that the blocker is going to pop out. Now, the ABCs of lung isolation. A is know your anatomy. I know you all know your anatomy. Tracheal, bronchial anatomy, that's what you do for a living. I was very surprised to read this study out of the University of Iowa. They were studying, one very experienced thoracic anesthesiologist was studying his own colleagues, okay? And they knew he was going to study them, and they were randomly assigned to put in blockers and double lumen tubes, and then he would come in and check to see if they were well positioned. He found out there was a 38% incidence of major malpositions. This wasn't minor things. This is a consultant anesthesiologist in a teaching hospital about to start a case, and the left-sided double lumen tube is in the right mainstem bronchus, or some other similar major mistake. And he thought that the most critical factor was that the anesthesiologist's knowledge of endoscopic bronchial anatomy. I mean, they should be ashamed. I mean, really, okay? I thought, well, we could do better at my hospital, you know. So I designed a test for our anesthesiologists. This is one of our test questions. What's this structure in the yellow circle, okay? Is that the right bronchus intermedius, the left upper lobe bronchus, the left mainstem bronchus, the right middle lobe bronchus, or the right upper lobe bronchus? It's the left upper lobe. How can you tell? You see these white lines? Well, first of all, you see this carina. You see segmental divisions on both sides. It's not the main carina, okay? The main carina, you might see the takeoff of the right upper lobe, but you don't see segmental divisions on both sides. So this is a secondary carina. So now, are we down the left side or the right side? Well, you see these white lines, these longitudinal elastic bundles. They go down the posterior wall of the trachea. Next time you do a bronchoscopy, watch. Posterior wall of trachea, posterior wall of the mainstem bronchi, and on the left side, they all go into the left lower lobe. So that's left lower lobe. So by default, that's left upper lobe. Now, my group of consultant anesthetists didn't know this anatomy either. So it's not that we're all stupid. It's just that most of us, when we were training, were just taught to get the tube to the cords. We weren't taught what to look for beyond the cords. So we have a website. Some of you may be familiar with it. On our website, we have a bronchoscopy simulator. We were showing this yesterday in the workshop, for those of you who are there. On the simulator, there's basically like a GPS here, and the orange line is the bronchoscope. And over here is an actual bronchoscopy. And you actually drive the bronchoscope around by clicking on these orange arrows here at the bottom, okay? And labels come up and tell you what you're looking at. So tonight, if you're not busy, you can go online. It's completely free. There's not even any advertising, you know, unlike Facebook. You can learn your bronchial anatomy. And I think it's really useful for teaching residents. Now, for the first 2 years we had this online, we made people do the quiz. The quiz that is 16 questions. And the quiz was pretty tough. So here is the first 2,000 people. And this is percent correct. And I broke it down into junior anesthesia residents, junior registrars, senior residents, consultant anesthetists, and consultant thoracic surgeons. And everybody's about 50%. And then when they used the simulator, everybody improved 15%. And this was, you know, statistically significant. And then I asked people at 3 months to take the quiz again. Because apparently, if you remember something for 3 months, it's gone into some other part of your brain, and it's now into long-term memory. And the results were quite surprising. The junior residents had actually dropped off. The seniors and the anesthetists hadn't changed, but we saw a huge improvement in the staff thoracic surgeons. So there's no truth to the rumor that they can't be taught. So A is know your anatomy, B is use the bronchoscope, and C is look at the chest imaging. Okay, here's your case Monday next week. 60-year-old woman who previously had, my bronchus, that just died. You got another one of those? Oh, there it comes back. Okay, she had a previous right upper lobectomy for cancer. She presented with hemoptysis. She's got a recurrence of the cancer in her right middle and lower lobes. Yeah, keeps dying. Anyway, so I really wanted to use a left-sided double lumen tube for this patient. Now, does anyone think they might have a problem getting a left-sided double lumen tube into this patient? You're all no problem at all. No sweat. Well, I was a bit nervous because she's got this incredible deviation of her tracheobronchial tree. But actually, as soon as we saw that, we were forewarned, which is being forearmed. So this was not a problem at all. What we did was to load the bronchoscope into the double lumen tube, into the bronchial lumen from the very beginning. Here we are looking at the carina, and now we're passing down into the left main stem under direct vision. Okay? Not using the bronchoscope like a Seldinger wire and ramming the double lumen tube over it, because they aren't designed for that. That wrecks them. You just put the bronchoscope in the end of your double lumen tube, and then it's just like turning on the lights, the headlights of your car, driving into a tunnel, okay? Very, very useful technique. Some people do it all the time. The only thing is it takes two people. It doesn't have to be another anesthetist. It can be you and the nurse, you and the surgeon. One to drive the bronchoscope and the other to position the tube. Avoid this. That's a laceration of the left main stem bronchus from a double lumen tube. Now, I want to specifically talk about difficult airways. And I want to tell you about this patient who I got to know. He's very normal looking. He doesn't look like he has a difficult airway. There's no warning. If you ask him to open his mouth, you could put a cricket ball in this guy's mouth. I mean, he opens that. He's Malin-Patty 0, okay? Now, this is his chest x-ray. He's actually got a cancer of his left lower lobe and an abscess. One of my colleagues induced anesthesia in this patient and went to intubate him with a double lumen tube, put in a laryngoscope, and could see no glottic structures. Nothing. So he just woke the patient up. And then my colleague came into my operating room and said, I have an interesting case for you. That's how I got to meet this man. He is a really nice man. He lets me use his picture. The thing about him is he has terrible arthritis of his cervical spine, osteoarthritis. Now, he's so nice that if you ask him if he has neck problems, he says no. But if he had to look at the ceiling, he'd have to do this. His neck is absolutely fused. Okay, so, again, Monday, you're at work, failed intubation, we know the problem. How do we get a double lumen tube into this patient? Any suggestions? No? You're all going to call in sick on Monday. Well, until 10 years ago, this is about the only option we had. Fiber optic intubation with a fiber optic bronchoscope, double lumen tube. That's Ron Pruganen from the MD Anderson, who's a friend of mine, demonstrating it. And, you know, we used to do this, but pediatric bronchoscopes aren't designed for this. They're barely rigid, barely long enough. But now we have fiber optic video laryngoscopes. This is the glide scope, okay? And this is amazing. This isn't double lumen tubes. This is just the glide scope saving failed direct laryngoscopy, a 94% save rate. I mean, that's amazing. I mean, even the best ice hockey goalie in the world, Carey Price of the Montreal Canadiens, doesn't have a 94% save rate. So glide scopes are a huge advance in managing the airway. But for years I've been struggling. You see, the double lumen tube doesn't want to follow the glide scope. And I kept trying to curve the tubes and use special introducers that the company designed, and I got really frustrated. So now what I do is get a single lumen tube in somehow, awake, asleep, whatever, then put the patient to sleep, and then we do a tube exchange. So this is the green Cook tube exchanger, and this is how it goes. But we use the glide scope. We've got a single lumen tube, out with the old tube, and now in with the new tube. And you'll see that this works very easy. That new tube just slides in there, just no problem at all. How long can the patient hold his breath? Okay, so there's an issue here. What I found is the companies have done different things with the bevels on their double lumen tubes. That's a Rush we were using. Mallinckrodt has a small bevel, and now we're going to do this with a Fuji tube. And Fuji makes a tube specially designed for this purpose, okay? And it's not always really, really easy, but it's far easier with this Fuji double lumen tube. Now, having said that, there are now many, many kinds of video laryngoscopes. This is the CMAC I think you're probably most familiar with that. I'm still learning the difference between the glide scope and the CMAC, or the CMAC regular blade and the D blade. Basically, if the patient can't move their neck or there's limited mouth opening, I think the glide scope or the D blade is better. But if it's just a mal-and-patty, a big tongue issue, I think the CMAC with the standard blades is better. And the thing is, if you do use the CMAC, you very rarely have to do this tube exchange. It seems to give you more room in the oropharynx to manipulate a double lumen tube in. Now, there are others. This is, as you know, many, many video laryngoscopes. This is the AirTrack. I've used the CMAC and I've used the glide scope in difficult airways with double lumen tubes. I've used this, but only in normal airways. So I can't really speak for it in double lumen tubes. In difficult airways, sorry. So just in a summary, we have some new equipment. We've got some better bronchial blockers, and we've got some better double lumen tubes. And particularly, we've got video laryngoscopes that help us a lot. However, we still have the three basic methods of lung isolation. We're going to have to use a single lumen tube as an endobronchial tube, bronchial blocker, double lumen tube, and don't forget the ABCs. Know your anatomy, use a bronchoscope, and always look at the chest imaging yourself before you intubate the patient. Thank you very much.